right. So I'm going to go ahead and we are recording now, and folks will be getting here in 22 seconds.
Sounds good.
And I will just tell everybody I hope they're having a good day. I hope they're safe wherever they're at. All right. Folks are joining in with us now, it looks like. So we're very happy to have you coming in. So we have a lot of folks in now. So thank you so much for joining our webinar today. My name is Dr. Reed Bowles. I'm the Chief Clinical Officer with Ichnotes, and we have today a very, very special guest. Her name is Susan Frager, and she is the leading authority on managed care and private practice business administration, and she's the founder of Psych Administrative Partners and the author of the Successful Private Practice Winning Strategies for Mental Health. Susan is a former care manager at what is now Magellan Behavioral Health, where she worked in the call center, outpatient, inpatient, and after-hours departments. And she has a background as an employee assistant therapist and personal performance consultant. And prior to that, has a work history with domestic violence and substance abuse and seriously mentally ill populations. So you have a wealth of knowledge, Susan, and we are just so happy to have you here today with us. Thank you so much.
Thanks, October. It certainly makes me sound very impressive.
Well, you are.
Thank you. But for the last 23 years, I have been a biller for pretty much all types of licenses, everything from psychiatrist, psychologist, social worker, all kinds of counselors, marriage and family therapists. So that's what keeps me very busy. So I guess let's get started. Here's what I want the audience to know is I'm not the sort of presenter that just reads slides, because you're going to be able to take these home with you and refer back to them. And what I've done is I've packed them with a lot of highly technical information. And the most important thing to remember, if you remember nothing else, is deep breath. Do not panic. Nobody's going to test you on this. It's okay not to understand the fine points, but the reason I'm giving this to you is so that you can see just how complex insurance really is. But again, not to panic, because what I'm going to focus on in the audio portion and in the question and answer portion of our webinar is the common mistakes people make. That's really where I want to focus, and that's where sorry, it looks like October. I've got a, what information am I interested in learning? So I'm going to kill that on my screen. Anyway, I welcome questions. I'd like to present as much time as possible for Q&A. So if it feels a little rushed, absolutely, we can go back. We can recover something. But I think it would be more engaging and more valuable than just having me read slides. So with that, I'm going to get started. This first section is really kind of a pros and cons about should you become contracted. And I really think most of you know this, unless you're just starting out. But I was just saying to a colleague, if there's one certainty about this industry is that things will change. They change constantly. So just because you're on one side or the other of the fence today doesn't mean that you will stay that way. A lot of it has to do with forces beyond our control, such as the economy, the pandemic, what the government does, things like that. So I'm just going to skip over these. Mostly, I think you will know what the pros and cons are of becoming contracted, but what I hope I have done in these next 3 slides is maybe give you some things that you're not aware of. So October, we can go to the next slide. One thing to keep in mind is the rates. Starting in about 2018, I noticed a trend, which I hadn't seen in 23. I've been billing since 1998, and I hadn't seen it ever. And that is rates started to climb a little bit. Now, whether they're keeping pace with inflation, yeah, probably not. But especially for some panels and in some areas, rates are actually better than you might think. It is extremely geographically dependent, and towards the end of the presentation, we are going to talk about approaching insurance companies for a raise. Thank you, thank you. Another thing that you want to go back one? Thanks. Another thing that I like to point out to people is you don't have to get on every panel known to mankind. There's always a sweet spot where practices can be very healthy just being on one panel or two panels. What you want to do is you want to evaluate who's big in your area and maybe only contract with that panel. I think the practices that are on every single panel are the ones that tend to struggle because their rates have been artificially pushed down for literally 95 to 100% of their patients. So I'm a big fan of hybrids. Pick the ones that you like, pick the ones that are easier to work with, pay better, use your own criteria. So, okay, we can go on. So I'm going to go over some myths and facts. I hear these myths a lot. The insurance company will dictate my treatment. Well, yes, but the true fact of the matter is that there are such things as clinical practice guidelines that are adopted by insurance companies. You can find them on any provider portal that you choose to go on. They're all right there. They're all public information. Most of the time, you don't even have to have a login. But the thing about these clinical practice guidelines is most of them are adopted from professional societies. For instance, in substance abuse, you have the ASAM criteria, which is American Society of Addictive Medicine, for instance. So for every problem or specialty, there's going to be a clinical practice guideline, but most of these are no longer written by the insurance companies. They used to be back in the 90s. That has changed. Now they are letting the professional societies write them, and then they're adopting them. So what that means is as a licensed clinician, you're pretty much going to be viewed as being bound by these clinical practice guidelines, regardless of whether you take insurance. And it's good to note that if you're ever cited before your license board or there's a malpractice action, the verdict is going to depend. They're going to look at what you did or didn't do with your patient and how that compares to the accepted standards of practice. So it's almost like there's not a lot of room for outliers, and it has nothing to do with whether you take insurance. Okay, we can move on. Audits. This is a common misconception I hear all the time. Oh, I'm out of network. They can't pull my treatment records. Wrong. Let's say you are out of network, but your patient says, hey, can I have a super bill or a receipt with the code so that I can get reimbursed? And you say, sure, and you hand it to them. Well, what the patient is doing when they submit that is they're checking a box saying, I agree that the insurance company can evaluate my treatment based on medical necessity criteria. It's for those of you who do billing and are actually familiar with 1500 forms, it's box 12. Okay. Box 12 reads, I authorize the release of any medical or other information necessary to pay this claim. That's true even out of network. So even if you're not submitting the claim, if it's coming from the patient is giving the insurance company that right, which means out of network therapists and behavioral health professionals can be audited. I think we went backwards. Nope, we're going backwards. Yeah. So the question, and I'm probably not going to answer this so much as I'm going to ask you to think about it, is this dictating treatment? And I think everyone has to decide for themselves their level of comfort when they consider this fact in deciding to contract. Okay, we can go on. Another one I like to hear, I hear a lot, although not so much in recent years. People have become a little more sophisticated. But you used to hear all the time, I'm exempt if I don't accept insurance from HIPAA. HIPAA freaks everybody out. I'm no exception. It's a pretty comprehensive and, quite frankly, scary law. But the truth is, at least part of HIPAA binds you. The privacy section of HIPAA binds you regardless of whether you're contracted or not, or even whether you bill electronically. Next slide, please. And here we go. I'm exempt if I don't bill electronically. That's a partial myth. You would be exempt from what's called the security rule portion of HIPAA. That's the part that dictates electronic standards, standard transactions, the security of electronically transmitted information. You would still be held to the privacy rule. But the security rule also includes just about anything else you might do. And if you're using ICA notes, even if you're out of network, you're not exempt from the security rule portion of HIPAA. Do you fax, email, text? Do you have a website? Do patients contact you on your website? Do you use an EMR such as ICA notes? Do you use an electronic scheduler? Any of those, you are not exempt. Sorry. Next slide, please. Here we go again with regards to insurance company dictating, although the difference is here now I'm talking about practice policies, like for instance, how many patients I can see, what my hours are going to be, can I charge for no-shows, that kind of thing. And again, this is a kind of a quasi-myth. There are going to be some sections in insurance contracts that do specify certain policies. But the one thing that's never been legally tested, and I would love to see this legally be tested, is the IRS has very strict rules about who constitutes an independent contractor and who does not. And the insurance company in each and every contract you sign is always very clear to state you're an independent contractor. And they do this because if you were an employee, they'd have to pay your Social Security tax, your Medicare tax, your state unemployment, your federal unemployment, and probably offer you benefits. So if the IRS ever ruled that you were an employee, that could have some serious tax implications. So the insurance company has to walk a line here about what they can and can't dictate to you in terms of practice policies. And I'm talking about non-clinical policies here. That doesn't mean they won't try to put it in the contract, because they will, and we're going to be going over what's in these contracts today. But I'm not a lawyer, so take this with a grain of salt, but it would be interesting to see a legal opinion on this. So there's some soft leeway, and what I always encourage practices to do is do what works best for your practice, as long as it's not illegal or unethical. But realize certain things might occasionally go up against a contract, and that's where maybe you might need to make a decision if kind of it all comes out. Next slide, please. This one is a personal, I threw this in because this is a very personal thing to me. Because I started my professional life as a clinician, I would go to see CEU events and conferences, and I would see it's almost more of a social thing than anything else. But there's this perception that if you accept insurance, you're less skilled as a clinician, and that somehow the people who have self-pay only practices are somehow better. I'm not going to answer that. I'm just throwing it out there. I'm going to ask you, is this a perception? Is this peer pressure? And ask yourself, how does accepting insurance change your clinical skill? I would imagine that if you're practicing ethically, you're assessing each individual patient and doing what's best for them regardless of their payment source. So I just want to remind everybody that accepting insurance, whether you do or don't, it's a business decision. It's not a clinical decision. Okay, next slide, please. All right, now here's some things that I think maybe not everybody's going to know. I have a lot of experience with people who say, oh yeah, I never read that contract. That put me to sleep. I don't even know what they're talking about. So I've distilled it down for you. I've read many, many contracts over the years, and they all pretty much say the same thing. And it's all incredibly legal and incredibly wordy and a bit off-putting. So the rate schedule, of course, number one. And what I'm finding is a real disturbing trend is that used to be they would show you the rates beforehand so you could make a decision as to whether or not you would sign. And I'm pretty much in favor of that, because why would anybody want to waste their time if you go through contracting and credentialing only to find that this payer has a horrible rate schedule and then you're just going to get out? It seems like that wastes everybody's time. But I am finding that certain payers just don't even bother with giving you the rates until after it's all said and done. The biggest thing about any contract, insurance participating provider contracts, is a prohibition on balance billing. Basically what that means is charging the remainder of your fee to the patient. So if your fee is $200 and let's say the insurance company contract rate is $100, you have to take $100 as payment in full, and that $100 is going to be split between what the patient owes in terms of copay and what the insurance company pays. And if it goes to deductible, the patient will pay $100, you write off the other $100. And you may not hold the patient financially responsible for your billing errors, or even if the health plan goes bankrupt. And it does happen. The only way to bill the patient for non-covered services or missed appointments or late cancellations is with advance notice of your practice policies in writing and getting the patient's signature. Coordination of benefits is always a huge nightmare for everybody. I've done whole webinars just on coordination of benefits. Essentially what it is it's the order in which plans must be billed if a person has more than one plan. It's frequently confusing, but it's in your contract that you'll abide by that. And patients do not get the right to choose which insurance company is primary. It's determined by the two policies and a very complex set of rules. Okay, next slide, please. There's a bunch of timelines. Most people know about timely filing, where you have to file claims within a certain time, but other things are also guided by time frames. That would be prior authorization, appeals, recredentialing. And the new one is attestations. I'm sure you've all seen it if you're in network, where CAQH makes you go in and reattest every 90 days. And now they're wanting directory updates, and it's not just CAQH, but it's each payer. They want you to go on every 90 days or 120 days and say, oh, nothing's changed, I attest. And it's a pain. If you guys are interested, I can tell you why that happens. Appointment access timelines. I'm not going to go into all of them. Typically for routine appointments, it's 10 days. And they do expect that if you're going to not take new patients, that you let them know, typically through that attestation process. Non-discrimination, believe it or not, it's one that trips everybody up. And most people, when they're reading the contract, if they're reading the contract, see non-discrimination and they think, oh yeah, no, I don't discriminate if somebody's, a different race or, ethnicity or religion or whatever. Yeah, that's what it means. But it also means that you're going to treat the members of that insurance plan exactly the same way as you would treat any other patient, including people who self-pay. That's what trips people up. Because, for instance, they might say to a patient, well, I can, if you've got insurance, I can see you, but I'm not going to give you an evening or a weekend slot. I've had people be called on the carpet for that. So it's actually not as innocuous as you might think. Next slide, please. The contract says you'll comply with pre- and post-payment reviews and prior authorization. A prepayment review is essentially prior authorization. It's evaluating the medical necessity of a service prior to treatment. Post-payment would be, okay, you've submitted a claim. Now we want the records to verify that not only that it was medically necessary, but also that your coding matches and your diagnosis and CPT codes match what is on the bill. So in other words, your records have to match what is on the bill. Site visits. There are such things as site visits, but typically if you're a small group or a solo, it doesn't happen unless it's Medicare or Medicaid. They want you to comply with dispute resolution and appeal. However, some of that is true even if you're out of network. This doesn't typically impact mental health, but there's new legislation starting in January on the federal level that says surprise billing has to go to arbitration. And what surprise billing is if the patient does not have the right to choose who their provider is. Say they're in an auto accident and get rushed to the nearest emergency room, and let's say the anesthesiologist isn't in network. Well, the patient can't be held to pay more because it was a quote unquote surprise. And even out of network providers are going to be forced to comply with dispute resolution and appeals. And of course, complying with credentialing. Next slide, please. It's kind of a no-brainer, but they put in there that you have to follow HIPAA, federal and state laws. And here we go again with the independent contractor. And what this means is you can set your own hours, you can close to new patients, you can decide who to treat based on specialty, as long as you don't discriminate by solely on the basis of are they a member of this particular health plan. But if you decide, no, I don't want to treat children, well, that applies to everybody. And of course, you can contract with any other payers that you want. This last one also trips people up, especially starting this time of year when things begin to change and new announcements are made as to new business. But if you sign a contract with one of the big boys, they have a little article in the contract that says we have the right to rent out the network. And that means when we rent out the network to a smaller company, let's say, then you're in network with that company. Now, legally, they have to give you notice and allow you to opt out, but half the time, when you get these letters, when my clinicians send me these letters, they're like, what the bleep does this mean? And so they don't take real good care in making sure that you really understand. That's not in their interest. And it also means that if a payer is acquired by another entity, then you're automatically to be considered participating with that new entity after the merger. I do see some questions coming in. I am glad that you guys are engaging. I'm looking at them. I'm going to continue just so that I can kind of hit the high points, but I'm really glad to see these questions and I'll be happy to address them. So keep them coming. We can move on. Okay. I don't know, October, did you ask people about how many do Medicare? She must be talking to someone. I realize that not everybody takes Medicare based on license, so we're going to skip over this a little bit. If people really want to know about Medicare, just signal me and I can come back. But the types of plans are very important to understand. And before I even get into the type of plan, I'm going to tell you the mistake everybody makes. I hear it just about every day. Well, this person has Blue Cross, and Blue Cross's copay is $20. Are you laughing? Blue Cross, Aetna, any insurance company has a zillion different products. I see somebody wants to know about Medicare, and somebody else wants to know, do billing companies check patients' insurance? Verification of benefits is a complex process. The only plan where the benefits do not change is Medicare. Medicare Part B is what covers mental health providers. There's always a yearly deductible. It's 80/20. But that's only traditional Medicare. There's also such a thing as Medicare Advantage. October, can we go on? Then there's such a thing as a Medigap or Medicare Supplement plan. These are great. If you get these, they are easy peasy. What it is it's a private commercial plan purchased, and it will cover either some or all of the Medicare deductible and coinsurance. Medigap plans are standardized. Doesn't matter whether it's Mutual of Omaha offering it, or AARP, or Colonial Penn, or Cigna, Blue Cross Blue Shield. If there's a letter on that card, for example, F, there's Plan G, there's Plan N, they're standardized, and you can Google these benefits. Another beautiful thing, there's no network. If you accept Medicare and Medicare pays, they will pay you. Okay. For those of you that can't take Medicare, like for instance, you're an LPC or an LMFT, do not try to bill a Medigap policy without billing Medicare. You will not be successful. There are some secondary plans that people have to Medicare that will pay a non-Medicare eligible practitioner, but a Medigap plan that's designated by a letter, October, I think we're going the wrong way.
Yeah, I'm sorry. It's switched over. Which one we are on, 15 or 16? No.
16, 17.
Does that
One
look
more.
right? Well, I'm
Yeah, one
sorry
more.
about that. So sorry.
Okay. Yeah. So that's okay. So you will not be successful if you try to bill a Medigap plan and bypass Medicare, but there are other plans you can bill and bypass Medicare, and I'll try to hit those. Yes, there will be a recording available. If a person has Medicaid, do they cover deductibles? That is going to be state by state, state dependent. We can move on, please. Medicare Advantage. This is huge, and it's poorly misunderstood. But the fact of the matter is about 45% of Medicare beneficiaries are now enrolled in Medicare Advantage. What it is it's technically called Part C. It is a private Medicare plan administered by a commercial insurer under license to CMS. What a Medicare Advantage plan can do is say the copay is different, the deductible is different, but if original Medicare allows the service, for instance, original Medicare pays for mental health, then the Medicare Advantage plan has to pay for it too. It typically includes all parts of Medicare into one plan. That's why it's popular, because it includes prescriptions. Sometimes it covers vision and dental. So people are liking it. And sometimes it's cheaper than buying a separate, paying for Medicare Part B, then buying a Medigap plan, then buying a prescription plan. Okay. Here's where people get confused all the time. Patient calls up, let's say they have AARP, United Healthcare, Medicare Advantage, and they have a bunch of different nice little marketing names. Okay. Yes, the slides will be available after the webinar also. Patient will call up and say, well, I have Medicare. Well, maybe they do, maybe they don't. Or the patient will call up and say, you're an LMFT, and the patient will call up and say, I have United Healthcare, and you take United Healthcare, and then guess what? It's really Medicare Advantage. And if you're an LMFT, you cannot bill United Healthcare Medicare Advantage. Now, I've seen it in the past where United Healthcare will pay an LMFT under Medicare Advantage, and then about 2 years later, they'll yank it back because, oops, so sorry, you're not eligible for Medicare. I've seen it happen. And then 2 years later, the patient is long gone, and you're just out the money for all the treatment. So be real careful. I always tell people, please, please, please get the cards, the insurance cards, front and back. Verify the benefits, and understand that these are big entities with lots of different types of plans, some of which you may be able to take, some of which you may not. Okay, we can move on. All right, Medicaid. Medicaid is tough to cover in a webinar, and I will tell you why. It's because there's 50 states, and every state can do things differently. I've explained what Medicaid is, what expanded Medicaid is, what children's health insurance is, but the bottom line is that each state determines their eligibility. Each state determines what they will and won't cover. So for instance, somebody asked, will Medicaid cover the Medicare deductible? In some states, yes. In some states, no. What other states will do is they'll say, okay, well, we'll cover it, but we'll only cover it up to the Medicaid allowable. All right, well, the Medicaid allowable is usually much, much less than the Medicare allowable. So you might get something, but not as much as you would get if Medicare had paid the claim. Next slide, please. Then there's Medicaid managed care, which think Medicare Advantage. Medicaid managed care is basically the Medicaid version of it. It's a private Medicaid plan administered by a commercial insurer. The difference, it's also the same. Covered services are not allowed to differ from what the state offers. The only difference is, but basically what the state is doing is they're pushing these Medicaid enrollees into a managed care plan so that the managed care plan can administer it, which frees the state from having to do it. And there are typically a lot of performance guidelines that these companies have, such as that maybe they'll reduce the incidence in diabetes, or they'll do a better job with care management, things like that. Couple things to keep in mind. Medicaid is always going to be the payer of last resort, whether it's a managed care plan or not. And what I mean by payer of last resort is that if the person has more than one plan, Medicaid is the one you bill last, always, no exceptions. And just like with Medicare, in order to accept a Medicaid managed care plan, you must be enrolled with your state's original Medicaid. Next slide, please. Duals are people with Medicare and Medicaid. I see this a lot. People, you know, it can be frustrating, especially in January when people have these deductibles. But if somebody is enrolled in Medicaid, you can't collect it. And then if Medicaid doesn't pay it, it's incredibly frustrating. Unfortunately, that is kind of the way it is. And some dual plans are combined and put into a commercial plan. Like on United Healthcare, you'll see something like, it'll have a little lingo like dual SNP. SNP stands for Special Needs Plan. So you really have to verify either online or on the phone or just by looking at the card. Next slide, please. I've given you a bunch of slides on the military plans. Some people use this more than others. Some things to keep in mind. TRICARE for Life, for instance. If a person has Medicare and TRICARE for Life, which is the military plan that people get put into once they have Medicare. If you're an LPC, let's say, Medicare will not pay, but TRICARE for Life will. Now, be prepared to have to argue to TRICARE for Life on every single claim that you didn't bill Medicare because you're an LPC, but they are obligated to pay it, and it will pay as if the person didn't have Medicare. In other words, they'll have a cost share. Next slide, please. CHAMP VA, most people don't really know how to distinguish TRICARE and CHAMP VA. That's why I've broken it out. The nice thing to know about CHAMP VA, no credentialing, no contracting. Next slide, please. VA community care is fairly new. It just came out in the last couple of years, and it's because the VA has been so overwhelmed for a number of years. I have listed how the VA community care program works. Always, whoever is the contractor for VA community care in your region, the biggest two are Health Net Federal Services, Wisconsin Physician Services, Palmetto GBA, and Optum, depending on your region. Always, a VA community care program is going to be a separate network. You have to be separately contracted and credentialed. If somebody calls and says, well, I have the VA through Optum and you're an Optum provider, doesn't mean anything unless you are contracted with this specifically. Next slide, please. Another poorly misunderstood, although it is getting better, is the Affordable Care Act and the Marketplace. I really think in many ways the Marketplace has been a good thing because Marketplace plans are required to cover 10 essential health benefits, including mental health. Next slide, please. But here's where people get into trouble. And it's even fooled me on occasion. They present you with a card. It's Cigna, it's United Healthcare, it's Blue Cross, it's whatever. And there's a little special designation, which really you kind of have to be a geek like me to even understand what that means. And I think insurance companies do that on purpose. I'm not a conspiracy theorist, and what a lot of Marketplace plans do is they use what's called a narrow network. In other words, they may take only a fraction of their network and say, you can participate in the Marketplace plans. And sometimes it's invitation only, meaning they'll reach out to who they want on the plan. And if they don't send you an invitation, you're not going to get put in there. A lot of people don't want to be on Marketplace plans because the rates are sometimes less. And or you may have to apply specifically to be contracted for Marketplace. And this is how they keep premiums, quote unquote, affordable. So the bottom line, and this is why I've put it in red, when your patient calls you up and says, I have Aetna, don't just jump and say, oh, sure, I take Aetna. It's got to be researched. Everybody makes this mistake. Everybody. You think that you're in network and you're not. Next slide, please. And before I move on, I think I saw a question about mental health carve out. The person asked, well, my patient has Blue Cross, but Magellan is the one that handles mental health, and I'm not in network with Magellan, so I'm considered out of network. That is called a mental health carve out. Typically, that's going to be seen with your large self-insured commercial employer plans, which is what I'm on now. This is what this is. And they can decide who they want because they're designing their own benefit. They can design who they want to address mental health, and typically they'll combine it with EAP. That's where you're going to see carve-outs. It's less common than it used to be, but it does exist. That's why you need the back of the card, because what you're looking for is you're looking for things that say MH/SA. You're looking for something that says behavioral health. You're looking for a little asterisk that says not affiliated with the big name on the front of the card. Or it'll say something like plan has chosen their own mental health coverage or something. You're looking for that. We can go on. Somebody's asking me about billing companies that I recommend. Please contact me afterwards for that. That's not something I can address here, but I'll be happy to speak to you afterwards. So self-insured plans are administered by what's called a third-party administrator. And And there's two different scenarios in this. One, it's going to be a large health insurer we've already heard of. And typically the network's going to be the same as for other products. If you've signed a contract, let's say with Aetna, you're most likely going to be in network for this part. Not always, but typically. In this scenario, it's a lot easier, but also a lot harder to understand because you're submitting claims to Aetna, and Aetna is sending you the money, but they're getting that money from a designated fund that the employer has set aside. Next slide, please. Here's where it really trips people up, is sometimes the TPA is going to be a much smaller corporation. And remember I said that insurance companies have the right to rent networks. They rent you out. This is where you see it. Because it'll have the Aetna logo on the card, and it'll say things like Aetna Signature Administrators or Meritain. Those are smaller networks owned by Aetna, for instance. And I'm just picking on Aetna, but they all have it. They all do this. Then what they do is you get a small third-party administrator, let's say Benefit Administrative Services, or something like that. But they're using Aetna, or there's a number of them. You probably won't even recognize the name of the company. They're very small. So these small companies don't have a network. They rent. And then what you do is you will still submit claims to the network. Then here's what they do. It's very complicated behind the scenes. They will reprice your claims, meaning they'll look to see that you're in the network. If yes, they'll look to see what your contract rate is. And then if not, they'll determine what quote unquote usual and customary are. And then they forward the claim to the third party administrator for payment. It is a much longer turnaround time for claims payment. Okay. And sometimes there's more than one network because with some employers, it's got to do with like state regulations or regional network availability. So they may put 2 or even 3 networks on, and it's going to depend on where you're located. October, it looks like somebody's asking for my contact information. Could you please provide that to everybody, actually? Thank you so much.
No problem.
Yeah, next slide, please. I'm going a little fast because I'd like to allow time for questions. Fully insured's a little easier. Let's move on because I think we still have a lot to cover, and I'm looking at the time. HMO versus PPO, you can move on. EAP, keep in mind EAP's special, very special. Billing can be non-standard, and that is something to consider if you are looking to contract with EAP, is how complicated is their billing for what you're getting paid. Next slide, please. Health sharing ministries, I included this because this is increasing exponentially. I think before this year, I'd never seen an HSM. In this week, this is the 3rd day of the week, I've seen one every day this week. People think it's insurance. It is not insurance. But it's going to fool you because they're using some of the networks that the third-party administrators are using. Be real careful. Get the card front and back and read the fine print. Okay, next slide. Liability. People don't understand much about liability, but worker compensation, auto liability, you can bill as a mental health provider, even if you're a LPC or LMFT or LCSW. It has to do with the liability carrier deciding that treatment is treatment is related to the injury caused by the accident. Next slide, please. I'm not going to go through billing of liability because it's way too technical. If you have questions about that, contact me. We can go on. Okay, contracting and credentialing. Everybody's favorite thing, including mine. Ha ha. Nope. Most people, I think, know what this is. Here's the biggest mistake people make, is they do not allow enough time. Can't tell you how many calls I get saying, hey, I just left a group practice. I'm starting up. I got my office and I'm starting Monday. Can you get me into Blue Cross? Okay, sure. So we can move on. I've got it all laid out for you. Here's an interesting slide. I like this slide because there are situations in which you can skip credentialing. Credentialing and contracting are related, but they are not the same. The slide before explained the differences. And if any of these situations apply to you, you can skip credentialing. So kind of keep that in your back pocket. We can go on. These are just references for you. Most people use CAQH. There are a few smaller ones that are kind of like CAQH. I remember back in the day, 50-page paper applications. Yeah, that was fun. CAQH can be kind of a pain, but it does make life easier. And it is free to you. Reattesting is every 120 days. Honestly, unless anything's changed, all you have to do is you have to go on there. You have to verify that your license is still valid, your malpractice insurance is still valid, and if you're a prescriber, your DEA and state prescription privileges are still valid, and upload the new ones. Next slide, please. I've broken it down also by payer. There are other nuances to contracting and or credentialing for the various plans. I'll just let you guys read that on the side. So October, you can move down a couple slides. There's TRICARE. I've also done Medicare and Medicaid. Medicare, believe it or not, most people think Medicare is a pain to contract with. It is actually my favorite plan to contract with. CMS has done a great job over the past few years in streamlining it. It's easy, it's fast. You can be Medicare contracted in sometimes as little as 2 weeks if you're doing it online. 2 weeks. Most commercial insurances, if you have to go through credentialing and then contracting, it can take up to 6 months. Sometimes it's a lot faster. It just depends on the payer. Okay, next slide, please. You can keep going. So I'd like to talk about getting a raise. That's what everybody wants to know about. People think, oh, you can't get a raise. Well, and of course, they're not going to tell you that you can, because then everybody would do it. But the reality is, yes, sometimes you can, but unfortunately, all clinicians are not created equal. It's going to depend on a few things, your specialty, geography, and some of these things you have no control over unless you've just graduated and gotten your licensing and you decide to move to nowhere, Alaska. Yeah, then geography will help you. But if you are in a metro area, you're going to have a tougher time. The worst places to try to get a raise are New York City, Los Angeles, and San Francisco. Basically because mental health providers are a dime a dozen, unless you're a psychiatrist. And most of the time when somebody in New York decides they want a raise, the insurance company is going to kind of look at it, laugh at you, and either say no or just never respond to you at all, because they figure if you leave, there's 10 more waiting to take your place. Next slide, please. Language, ethnicity, it does matter. More in mental health than in medicine, actually, because of the relationship that needs to form between the patient and the clinician. But there are other things that you can control. If you're in a large group, you will have higher bargaining power. If you work with physicians, disabilities, in partnership with the medical community, you're going to have a better chance. And quite honestly, just doing your time on the panel, having positive outcomes, good ratings, following the rules, that will play a role. Next slide, please. Okay, here's how to do it. Be honest with yourself. It's a lot of time and effort. Are you willing and able to do it? Because if you're not, don't start. Wait until you're ready. because once you start, they're gonna it's almost like a psychological game. It's like, who's gonna blink first? If you bow out, it's gonna be harder if you then try to do it again later. You want to assess your strengths, assess your local market, your competitors. Look at the online directory. Every payer has an online directory. You do not have to be participating to use it. You do not even have to have their insurance. It'll let you do it as a guest. But keep directory suppression in mind, because what's happening now is some payers, if you don't attest to those annoying little, oh, we need you to attest every quarter, eventually they're going to pull you off the directory. Now, what that does mean is that you're still in network, okay? Your claims will never be affected. But if a new patient wants to know if you are participating with, let's say, United Healthcare, they won't see you on the list online, okay? The reason is because this stuff has rolled downhill from CMS. CMS has said Medicare Advantage plans, their directories are too outdated. And CMS has said, you know what? We're going to fine insurance payers for out-of-date directories. So the insurance payers have said, yeah, not our problem. We'll put it on the clinicians, make them do it. That's where these attestations are coming from. It's all about money. Big surprise, right? Next slide, please. Another thing to keep in mind is all states have network adequacy requirements. That's things like, okay, there must be a certain number of providers of each type within so many miles and be able to see a patient within such a certain period of time, okay? Make sure you compare only people with your same specialty and your same license and your same characteristics. And please do not discuss this with your peers. It can be considered an antitrust offense. I'm not a lawyer. I can't really speak to why. And I agree, it does seem a little unfair given the way insurance companies operate, but unfortunately, that is the way it is right now. You can legally discuss this with anybody who bills under your tax ID, but keep in mind that just sharing an office space does not make you a group. And then ask yourself, well, what do you think is fair? And then add a cushion, because it's like selling a house in most markets, not the way it is in 2021. But in most markets, when you sell a house, you ask for more than what you're willing to take, and that gives the buyer, or that gives the buyer and the seller a chance to negotiate. And, you know, one party goes up, one party goes down, and then everybody's happy. Same thing here. Next slide, please. Write a letter. Very, very important. I'm happy to consult with people and review their letters, make suggestions. This is what you want to do, though. And by all means, don't threaten to resign. They don't care. They don't. You want to talk about why you are valuable to them. It's all about them. It's not about you. Next slide, please. Finding out who to send your letter to. Oh, that's fun. This slide and the next slide, and I think maybe even the next slides, have tips about this, because it can be very complicated. So October, if you can just show those real fast, please. You can keep going. Yep. Then send your letter, follow up, follow up, follow up, follow up, and follow up some more. They are not going to be in a hurry. They're going to want to see if you're going to follow up. Also, keep in mind that if it takes a while, that's actually a good thing, because it means they might actually be considering it. A no is real quick and easy. If they're going to say no, they're probably going to tell you pretty soon, if they respond to you at all. A yes is going to take several levels of management. Yes, I did say you cannot cross-communicate rates with other providers, as that is antitrust. That is correct. Unless those providers are in your group, meaning you all bill under the same tax ID. That's the one exception. Next slide, please. If you're denied, ask if there's an appeal process. An appeal. Ask if you can go on up the chain of command. Sometimes the people at the, well, all the time, the people at the bottom have less ability to say yes. So, hey, well, do you mind, sending this to your supervisor? I would really appreciate it. Stay nice. If the answer if there's no appeal, you can't go on, be nice, and then try again. Or decide that, hey, I'm done with you. But don't threaten to resign, just do it. Is that it, October, or is there anything else? Oh, yes. If they say yes, okay, get it in writing and make sure they share it with the claims department. I've seen a lot of times where a pair will say, oh, sure, yeah, here's your better rates, and then they never bother to tell the claims department, and you get paid the same old, same old. You want to ask specifically which plans, policies, or networks this applies to, because we've just gone over all the different types, and it will most likely not include managed Medicare or Medicaid, because those rates are determined by the government entities. Marketplace plans might be excluded, so you really want to be very careful. The effective date is going to be determined by the date of service. In other words, if your effective date is September 1st, but you're billing on September 1st a claim for August 30th, it's going to be paid at the old rates, even though you billed it on September 1st. Next slide, please. Monitor your remittances, and if you're underpaid, call, challenge it. You will have wasted all your time if you don't challenge it. Next slide, please. Okay. I know I rushed a little bit. It is an awful lot to cover. I'm happy to answer questions. I think they've put my consultation contact information. I'm happy to consult with you individually. So I'll turn over for questions. October, did you want me to do this?
Yeah, no, some of the ones that we had gotten at you originally when we asked what people were interested in learning, you covered a lot. We got a lot about negotiation. Okay, we got a lot
Okay, good.
about that. So, and you covered how to be successful with an appeal process, submitting claims, how to submit successful claims for different insurances with their different forms. We got a few questions about that.
Unless you're a facility provider, billing for a facility, the form is the 1500. The only exception would be employee assistance, and that's determined by the payer because it's non-standard. Can we discuss being out of network? You know what? To who asked that, that is a whole other webinar, and I went kind of, Ike Notes and I discussed this at great length because out of network is a whole other webinar. With regards to hiring a company to credential, I can certainly talk about that a little bit. There's pros and cons. The pros being they know what they're doing. They can typically get it done faster. The con, of course, is that it is more expensive. Somebody asked if is there a difference for group versus individual provider rates? Typically, yes. But typically only for commercial plans. Medicaid is typically set by the state. And those rates are going to be determined by the state, by your zip code, by your license mostly. Anything that I'm missing? Do you see anything that I'm missing?
Looks like a lot of people are just asking how to get on insurance panels. I've got several questions about that. How to get on insurance panels. One was specific to states: Indiana, Nevada, Florida, and North Carolina.
Indiana, Florida, Nevada, and North Carolina. Okay. Florida, I know a lot about. My advice, good luck if you want to be on Blue Cross of Florida. They are by far and away the most difficult payer to get on with. Their behavioral health is done by New Directions. They are always quote unquote full. Indiana is an any willing provider state. Any willing provider is really good. It's a state law that I think maybe about 5 or 6 states have, and it basically says if you're willing to accept the rates, if you're willing to abide by the rules, they have to take you. Medicare, Medicaid, of course, is also any willing provider. Always. Getting contracted in credentialing, were there other questions about that?
I saw what I did see. No, but what I did see is one good question here is telehealth going to be permanent after COVID-19 is contained? What are your thoughts on that?
Oh God, I wish I had the answer to that. I would be so ready to retire right now. The best guess is contact your state legislators, on the state and federal level, your representatives. For government plans, it's going to depend on the government renewing the public health emergency or PHE. Word on the street is that even though it expires sometime next month, they're probably going to extend it through the end of 2021. With Delta surging, I think it's probably going to be longer rather than sooner. And there are quite a few states now that mandate telehealth on a state level. A good resource is Google it. It's called the Center for Connected Health Policy. It gives you a lot of information about who covers telehealth, and I would suggest signing up for their mailing list because they're always sending new information, because this is an ever-evolving field. But yeah, I don't have any guarantees. And as we've seen, there are so many complicated plans that the decision to pay for telehealth depends ultimately on the type of plan. And you get, say, a self-insured plan, that's up to the employer. Doesn't matter what the state says. So that's a tough one. Center for Connected Health Policy. I am seeing contact information. I think it's CCHPA. How about I do this? How about I shoot that to Notes, and they can distribute it to you for that resource. I'm seeing a lot of different questions about, well, what are the best panels? Should I hire a credentialing company, a billing company? Those are pretty individual questions. And for that, oh, thank you. I see that somebody's found it. Google is a wonderful thing. Those are pretty individual questions because they are very location specific, specialty specific. What works in one place is not the best strategy for another place. So those are unfortunately more individual questions. I can and do consult with people on those. The other thing I do consult with is, let's say you're using Notes and you have just a really complex claim and you're pulling your hair out, and let's say Notes can't really help you because they're teaching you how to use the software, but they're not a billing service. You can call me and I do one-off kind of billing consult, like on a specific claim. It does require, a business associate agreement, to be legal under HIPAA, but I do that as well. Did I miss anything? It looks like we're kind of out of time.
Susan, I appreciate you because the information you gave has been extremely helpful. So thank you for your presentation. I just want to remind everyone in here today that in this webinar that Notes has a robust calendar system along with a billing system within our EHR, and we can handle all your practice management needs. We are most known for our clinical content and the ability to be able to create a visit or session note in about 2 to 3 minutes. However, Notes is different than other EMRs, and that we allow you the choice of a clearinghouse that you want to use. And we have a large list of clearinghouses. Most other EHRs lock you into their clearinghouse and you have to pay them the percentages that they insist on instead of being able to shop around and get the best price and rates that work for you. Another advantage of Notes compared to other EHRs is that our training and support are free and unlimited. So we help handhold you through the billing process. So now everyone today will receive a recording of this webinar, and we'll send out slides as well. And thank you for attending, your participation. There were a lot of fantastic questions. So, and Susan, thank you. I hope
Oh,
everyone
you're
has.
very welcome. Anytime.
Thank you. I hope everyone has a wonderful day.
All right. You take care. Enjoy. Stay safe, everyone.